We will move on to the second lecture, which is by Dr. Dhanushka Rathnayake, who is going to speak on who let the androgens out, an update on polycystic ovarian disease. Dr. Rathnayake, over to you.
Good evening, everybody, and thank you, sir, for your kind introduction. And thank you. I would like to thank CCP for this opportunity granted to me. My topic is today: who let the androgens out? An update on polycystic ovarian syndrome. Without much ado, I will go straight into the topic. This is a clinical case we commonly encounter in our clinic setup. A 20-year-old girl presenting with irregular menstrual periods for 2 years duration. She's obese with a BMI of 28, and there are ample features of insulin resistance such as acanthosis nigricans, and she's HER2 with a Ferriman Goldway score for possible 22, and she had no clitoromegaly. The $1 million question is, what does she have? There are multiple possibilities. If I state them: polycystic ovarian syndrome, Cushing's disease, hyperprolactinemia, non-classic CH, thyroid dysfunction, androgen secreting tumors. All of these diseases can give rise to this clinical scenario. Our topic today is polycystic ovarian syndrome, which is a diagnosis of exclusion. I will go into that. Then we have to suspect whether the patient is having polycystic ovarian syndrome. The things for polycystic ovarian syndrome are any woman of reproductive age and with a history of irregular menstrual periods and symptoms of hyperandrogenism, acne, hirsutism, male pattern hair loss, and the presence of overweight or obesity should further raise suspicion about the polycystic ovarian syndrome. And if you encounter these features in a patient, alarm bells should ring in your head. This could be polycystic ovarian syndrome. Then how to diagnose whether the patient has polycystic ovarian syndrome or not? It is done according to a diagnostic criteria. The most common one is Rotterdam criteria, which was published in 2003. But there's an evolution of diagnostic criteria. I will discuss about them and the most recent ones. And the first one published was NIH consensus criteria, published in 1990. It required all three criteria mentioned here: menstrual irregularity due to oligo and ovulation, clinical and or biochemical evidences of hyperandrogenism, and exclusion of all other possible diseases. Then the Rotterdam criteria came in 2003. It required 2 out of 3 criteria: oligo and ovulation, clinical and biochemical signs of hyperandrogenism, and polycystic ovarian morphology by ultrasound. Here I would like to highlight that from these 2003 things have evolved up to now, and this definition of 2 or more follicles in either ovary measuring 2 to 9 millimeters in diameter and increased ovarian volume more than 10 millimeters have changed now. If you are it all depends on the ultrasound machine you are using. If you are using a ultrasound machine that has more capability than 8 megahertz, the follicle level goes up to about 20 follicles for diagnosis of polycystic ovarian in the recent guidelines. And the key problem in this Rotterdam criteria was, as perceived by some clinical societies, was that was possible to diagnose polycystic ovarian syndrome without evidence of hyperandrogenism. So in 2018, another definition came by Androgen Excess Society. They required all of these criteria: clinical and biochemical signs of hyperandrogenism, and ovarian dysfunction as evidenced by oligo and ovulation, and polycystic ovarian ovaries on ultrasound, and exclusion of other androgen excess or ovulatory disorders. So I would like to highlight here the presence of hyperandrogenism was mandatory in this Androgen Excess Society definition in 2008, and making it a pivotal to diagnosis. Then this is a common problem we encounter in our clinical scenarios. The patient get referred to us because of she has found to have nothing else but having polycystic ovaries on the ultrasound. Then if she has no hyperandrogenism features, no menstrual dysfunction, she needs no further evaluation. She does not have polycystic ovarian syndrome, because having follicles or polycystic ovarian morphology is common in can be common in reproductive age females. And why do we need to worry about polycystic ovarian syndrome? and it is associated with risk factors for cardiovascular disease such as obesity, glucose intolerance, dyslipidemia, fatty liver disease, obstructive sleep apnea, etc. And it is associated with a poor quality of life and well-being, and it has a massive psychological impact on the patient. And majority of these patients have poor diagnostic experience related to the long delays and inadequate health information. It is stated in research that it takes about 2 to 3 years for a patient to come to a diagnosis of polycystic ovarian after the initial presentation. Then, what are the clinical features that we should look out for? Menstrual dysfunction, hyperandrogenism such as acne, male pattern hair loss, hirsutism, and features of insulin resistance, features of sleep apnea, mood disorders, mainly depression and anxiety, impaired quality of life, and eating disorders we have to be on lookout for. And I would like to highlight that when using Rotterdam criteria, many patients can be diagnosed based upon the history and the physical examination, and history of menstrual irregularities, and based on the menstrual irregularities and clinical signs of hyperandrogenism. Our history and physical examination should be geared towards to exclude other differential diagnosis and come to a diagnosis of polycystic ovarian syndrome, and to be on the lookout for associated complications. And other important aspect I would like to draw your attention to is whether when the patient comes to you complaining of a menstrual abnormality, does she really have a menstrual cycle irregularly? As per recent guidelines, when the patient, I am talking about the adult females, the definitions of oligomenorrhea differs when the patient is in the adolescent age, and when the patient has more than 35 days for a menstrual cycles or has less than 8 cycles for a period of 1 year, she can be diagnosed as having oligomenorrhea. And the point I would like to highlight is having regular menstrual cycles does not rule out the patient is having anovulation. Even the hyperandrogenic women, even though they are eumenoric, may be not ovulating. So to come out of that difficulty, the possibilities is measuring luteal phase progesterones and the ultrasound mechanisms. And the other thing is the Ferriman-Goldway score to assess the degree of hirsutism. And this Ferriman-Goldway score can be subjective, and it varies according to the racial background. If you take the East Asian population of the world, they have less body hair compared to the Mediterranean and the South Asian women who have comparatively more hair. So Ferriman-Goldway score of about 5-4 may be not very significant in a female of Middle Eastern or South Asian origin, but it may be very significant in a female of East Asian origin. So we have to be careful in interpreting this. And if the patient has virilization or rapidly developing hirsutism, we have to be careful whether the patient is having any sinister causes of hirsutism such as ovarian malignancies and androgen producing malignancies, etc. And for the investigations, we should always be in the lookout for whether the patient is pregnant, and oral dexamethasone suppression test to rule out to screen for Cushing's disease, and prolactin, thyroid stimulating hormones, FS, and the role of LH is contentious because the LH to FSH ratio is not a criteria for diagnosis of polycystic ovarian syndrome, and estradiol levels, early morning 17-hydroxyprogesterone levels to measure to look for non-classic CH. And when we are measuring androgen and DHEAs, androgens that we can measure are total testosterone in our setup. The problem with total testosterone is it lacks precision and sensitivity. On these polycystic ovarian patients, the testosterone levels are only raised to a mild degree of raise from the normal levels. So in that levels, precision and sensitivity can be low. And other problem is about in 10% of the patients, only abnormality and the only androgen that can be elevated is DHEAs, and the 25% of the polycystic ovarian patients may have elevated DHEAs as well. So in the case of the patient is having normal testosterone, we would guidelines recommend that you go for a DHEAs testing. And the AMH levels can be elevated though in the upper limit of the normal. The problem with the AMH is it does not have international standards, so but it is in the clinical literature. It can come up in the future as a investigation for the polycystic ovarian syndrome. And one of the other common clinical problems we encounter is if the patient has been started on a treatment, multiple majority of these patients, when they present to clinicians, they are on combined oral contraceptives or any other treatment. We have to be careful when interpreting tests when the patient is on combined oral contraceptives. So we have ideal method would be to stop the combined oral contraceptives for at least 8 to 12 weeks and measure the serum androgens and sex hormone binding globulin levels when they become to normal levels. Then I will go into the pathophysiology. Why this female got polycystic ovarian syndrome? There are multiple hypotheses and multiple methods circulating. I will go into neurohormonal aspect. It describes increased frequency of GnRH secretion, which in turn increases testosterone output from the ovaries and the adrenals. And these androgens can be extragonadally converted to the estradiol and the estrogens, which will act on the endometrium and give rise to endometrial hyperplasia and endometrial carcinoma. And in turn, this testosterone acts on the hypothalamus and it blunts the negative feedback effects of estradiol and progesterone on the hypothalamus to reduce GnRH secretion. There are other non-reproductive hypotheses also come into aspect. One of the main one is the insulin resistance and the beta cell dysfunction. The evidence suggestive of this was published in JCEM in 1987, rather old data, Dune et al. And they compared two cohorts of polycystic ovarian patients who were, one group were lean, one group with increased BMI. There was, irrespective of the BMI, it was found to have the patients were found to have high insulin levels. So it was found to be the patients, high insulin levels were integral part of the pathophysiology of polycystic ovarian syndrome. And other mechanisms that were put forward, so hepatovisceral fat excess, iron overload, sympathetic overactivity, and there is a strong genetic aspect to polycystic ovarian syndrome. There are novel genetic loci being found out, and the biological pathways being found out in the recent literature. And in the future, there could be novel methods of prognostication and prediction of this disease. Then I will go into the treatment of this disease. There are main 5 targets of treatment. First one is resolution of hyperandrogenic features and the menstrual abnormalities. Second is the prevention of endometrial hyperplasia and the carcinoma. Third one, management of underlying metabolic abnormalities and reduction of risk factors for type 2 diabetes and cardiovascular disease. And the contraception and the ovulation induction for those who pursuing pregnancy. I have tried to summarize the management options that are available. For menstrual abnormalities, hormonal contraceptives can be the first line. For obesity, exercise and lifestyle interventions. Second line, pharmacotherapy, and the bariatric surgery is also an option. For the fertility, confidence citrate and the letrozole is now coming up as the first line management. GnRH treatment as the second line. It is practiced in the centers of excellence. And the other problem for impaired glucose tolerance and the diabetes, metformin is the first line treatment. And hirsutism, acne, and the cosmetic aspect, hormonal contraceptives, and the anti-androgen therapy can be the treatment. So I'll go into the details of this treatment. Metformin also can be used as adjuvant therapy to prevent ovarian hyperstimulation, and the Endocrine Society guidelines in 2013 suggested against metformin as the first line for they suggest against metformin as the first line for weight loss, and against statin therapy and insulin sensitizers. Here, insulin sensitizers are now coming up in the literature with evidences that the patient can reduce insulin levels and increase ovulation with thiazolidinediones. It may come up in the future as a treatment modality. When we approach the treatment of obesity, obviously weight loss is the way to go forward, and how to approach that is diet and lifestyle modification, pharmacotherapy, and if necessary, bariatric surgery. It is crucial for the management of polycystic ovarian syndrome. In the studies, it has been found that loss of body weight of 2 to 5% from the baseline helps to restore ovulation and insulin sensitive in obese and non-ovulatory women. But the problem with this randomized trials and long-term data on weight loss. Bariatric surgery is a viable option, and there are also some studies published into JCM in 2005 that involved 17 women with polycystic ovarian syndrome, had a BMI of 50, undergone surgery with a loss of weight 42 kilograms over 12 months. They had resolution of ovulatory cycles, improvement in insulin tolerance, insulin resistance, hyperandrogenemia, and hirsutism scores. The evidence for weight loss, metformin as a method of weight loss is contradictory. There are some studies for metformin and some studies against metformin. So to be unfair, in the safe sides, diet and lifestyle modification is put forward as the first line treatment for this. The liraglutide also is showing promising results. There are studies published in 2017 that suggest liraglutide, when combined with patient with poor response to metformin, has shown weight loss. Then we come to the treatment of menstrual cycle irregularities. The first line treatment is combined oral contraceptives. It helps to control menses for contraception, improving androgenic symptoms, and it antagonizes the intermittent proliferative effects of estrogen and cutaneous benefit for hyperandrogenic manifestations. Those who cannot tolerate combined oral contraceptives, cyclic progesterone-only treatment or IUDs can be utilized. Metformin can be utilized as a second-line treatment in select groups for obesity, and it has shown an improved for menstrual irregularity. It has shown increased ovulatory rate, but it is contentious whether it is enough to reduce the risk of endometrial carcinoma. We can see whether the patient is ovulating by utilizing luteal phase progesterone or ultrasonic scans. For the cosmetic treatment, options available are the hormonal contraceptives, and how long to treat how long is a problem, but it is going on case by case decisions. And then we can start androgen therapy if the patient is not satisfied with the clinical outcome of after treating 6 months with the combined oral contraceptives. For example, spironolactone can be used. The problem with these things is this treatment is risk of prevent this anti-androgen therapy can prevent development of normal external genitalia in early pregnancy in case the patient becomes pregnant. So it should be stopped 3 months before the conception and should be used with a reliable method of contraception. And other treatments available are laser treatment, mechanical methods, dermatological interventions such as antibiotics and retinoids, and topical treatment also can be utilized. Other metabolic complications, prevalence of impaired glucose tolerance is sky high in these patients, 30 to 35%, with the prevalence of frank type 2 diabetes in 3 to 10%. And the diagnosis of polycystic ovarian syndrome confers a 5 to 10-fold risk of type 2 diabetes mellitus. Endocrine Society recommends OGT2 over HbA1c for screening purposes. Metformin is put forward as the first line of treatment, and studies in the polycystic ovarian syndrome are still too small to determine whether the patient metformin prevents diabetes or not. So we can go by diabetes literature. And non-alcoholic steatohepatitis, as we can say, in obese patients can be a problem, and guidelines suggest not actively looking for that, but if it encounter that, it needs referral to the suitable specialties and being adhered to. Both weight loss and metformin appear to have metabolic and to improve metabolic and hepatic functions. And how to address dyslipidemia and the role of statins? It is approaches same as for other patients with dyslipidemia, and exercise and weight loss are the first line approach, pharmacotherapy if needed. Statins are useful for treating the dyslipidemia, but from the polycystic ovarian syndrome aspect, it is not advocated and it is not recommended. For obstructive sleep apnea, we should be on the lookout for a possibility of obstructive sleep apnea. Use a questionnaire like Berlin's questionnaire, and if in the case it comes as positive, we should go for a formal polysomnography and assessment. Mental health compromises of a large component of this patient's care, because they are more prone to poor body image and anxiety and depression. We should be always in the lookout for these problems in this patient, and suitable referrals and treatment interventions should be taken. And the fertility is a major issue in all these patients. Letrozole is now coming up as the first line treatment, bypassing the clomiphene citrate. Cost and the availability is a problem with letrozole, and clinician must always discuss this is not a FDA approved still, and alternative as a clomiphene exists, and it has low adverse effect profile and a low high success rate compared to clomiphene citrate. Unfortunately, these polycystic ovarian syndrome patients are associated with higher rate of pregnancy morbidity, such as higher rate of miscarriages, and they are associated with GDM and hypertension. So we should be on the lookout for them as well. So, but getting the patient pregnant and the reduction of body weight is not the end of the story here. The patients carry their legacy into the adult and the middle ages as well, with high prevalence for diabetes and impaired glucose tolerance I mentioned before. So we should should be a holistic approach of care of this patient. So thank you very much for listening. I will conclude my presentation.
Presentation. We don't have any questions online, but if the judges have any questions.
Yeah, thank you for that presentation. I only want a clarification. Can you please tell me the exact connection between insulin and PCOS? How are they just associations, or is there a biochemical connection between them?
The exact mechanisms I am not aware of, sir, but there has been ample evidence to suggest that increased prevalence of impaired glucose tolerance and diabetes in these patients, with evidence.
And in your initial assessment, you also suggested we should do prolactin and TSH levels as well.
Yes.
Why was that?
So, because the patient is presenting to us with the initial presentation would be menstrual irregularities and oligomenorrhea can be a possibility. So in that, hyperprolactinemia can give rise to ovulatory dysfunction, and the thyroid dysfunction also can give similar pictures. So
Okay, so it's there's no connection with PCOS itself, only
no,
the manifestation,
to
presentation.
for the diagnosis.
Okay,
Right.
thank you.
The question is, can liraglutide be used as monotherapy for diabetes in PCOS in an obese patient?
There has been studies for that. In the 2017 published data that liraglutide has proven benefits against the placebo study. So there are evidence favoring that.
Can I ask what it does? In what sense does it? What is the outcome? What is the outcome that is achieved by the use of liraglutide? Is it weight loss or control of diabetes, or what's the outcome measure?
Outcome measure has been the weight loss.
Weight loss. So thank you very much, Dhanushka Rathnayake, for your brilliant presentation.